Okay. Now let's come to a little more basic topic in our implantology, which is understanding the quality of the bone. Because we are going to place the implant inside the bone and we want to understand what are the basic types of bone which are present in the jaws. So the bone which is present on top of the area where the teeth are is the alveolar bone, and that resorbs, and we have the basal bone. So you must have heard about basal implants or basal implantologists. What they do is they don't regard the alveolar bone as a good stable bone for the long term. They place the implant in engaging the basal bone, and if there is no basal bone, ऐसा कभी होगा नहीं, because basal bone is a very highly structural unit. Any case where the bone is even lost, you will always have basal bone, because alveolar bone में अंदर के साइड में there are a lot of blood vessels or nerves which are inside the bone. Okay, but basal bone has very less blood supply, so it is very resistant to resorption also. So we'll come to this in more detail. So as you can see here, this whole area where the root was embedded is the alveolar bone, and only this lower area is the basal bone. This is not only in the mandible, it also occurs in the maxilla. So in the maxilla we have the nasal cortical floor, which is the basal bone of the maxilla. We have the palatine bone, which is the basal bone. We have the pterygoid plates, which is the basal bone. We have zygomatic arch, which is again the basal bone. In the lower, we have the external oblique ridge, we have the base of the mandible, which is again the basal bone. So these bones are very resistant to resorption, and they are very D1 good quality bone. Okay, that's why a lot of basal implantologists will put their implants in the basal bone. They will drill till the basal bone. But when we talk about alveolar bone, it is much more nourishing, it is much more capable of osseointegration, it is having a lot of blood supply, and that also has two parts. The outer part of any kind of bone is known as the compact bone or the cortical bone, which is slightly structurally more mineralized, and the inner part of any bone is the trabecular bone, which is less mineralized, it has more blood supply, it has more blood vessels. That's why if you have done an extraction anytime, you would come to know, like if you have done a disimpaction, starting में जब हम third molar के area में when we drill our burr, there is hardly any bleeding, but suddenly the burr slips inside and we get blood and we get scared. Have I hit the inferior alveolar artery or something? But actually it's not the case. We are not going so deep. We have only reduced the compact bone or cortical bone in the first part where it was avascular, and when suddenly we felt that dip, it went into the compact bone, and because it went into the alveolar bone, because the alveolar bone was very highly innervated with lot of blood capillaries, that's why it bleeds. Right, so in a CBCT scan, this structure looks like this. So you have a compact bone or known as cortical bone, which is whiter or denser in color, and then inner part you have is the alveolar bone, which is more having trabecular and less density, more trabecular. So it is the actual bone which we utilize for osseointegration. Right. So this is how we can see and visualize in a lower anterior how this bone looks like. Okay, so 1 minute, I'll add this person. Yeah, all right. Dr. Rishikesh, can you see the slides now?
Yes, sir.
Okay, got it. Okay, so we have this cortical bone surrounding the alveolar bone. And in the alveolar bone, we have all the nerves, blood vessels, which we will study in detail in the next lecture. So based on the density or the alveolar bone quality and the quality of the cortical bone, many classifications are given to ease us to plan our implant practice. Whenever there is a complete alveolar bone also is very dense, the trabeculae are very less, it's almost looking like the outer rim, that is the cortical bone, it is known as D1. So D1 kind of bone will be very dense. So what it means basically is that the internal structure of this particular bone is very dense. Okay, so when something is dense, it means it has less blood supply, just like the basal bone. And whenever something is having empty space, or internally it is more trabeculated, it is having more blood supply, it is having less mineral content. Okay, so as we go from D1 to D4, we'll find that D1 is the most dense, then D2 is having slightly more trabecular pattern, more vascularity, more blood cells than the D1. So the outer rim is going to be dense, but the inner part is going to be more porous. Then we will go into D3, where it is more porous, even porous, less dense, and D4 is the most porous bone. So D4 is less dense, less mineral content, more bleeding, more blood supply, less mineral content, so less appears like bone, less feeling like bone. It will feel as if it's very mushy. Okay, and when we drill into a D1 bone, it feels really hard. It feels like you are drilling into a cement block. All right. So for understanding and feeling everything of what I have said right now, we, in the first part of our hands-on, we have special models where all of you will actually drill and you will feel how drilling into D1, D2, D3, D4 feels. Because this is most important part of our implant surgery. We are going to understand how to change the type of implant. We are also going to understand how to change the type of loading which we want to do, and we are going to change the type of drilling protocol based on the bone we feel when we dig into the patient's bone. Okay, so for example, if you are having a D1 bone, then my drilling protocol is completely different, my choice of implants is completely different, my size of implant is completely different. When I am drilling into D4 bone, the choice of drilling protocol, the choice of drills, the implants become completely different. And we will slowly build up on this knowledge and come to that. I want all of you to not follow one system, because this is not a course which supports one particular system. That's why we have 3 4 different systems to use in the clinic. We also use it every day in the clinic, and we decide which system to put based on the kind of bone the patient presents, the kind of anatomy the patient presents, and we try to make our implant practice more simpler, right? Okay, any doubt in this? Anything anybody wants to ask? Okay, I'll go ahead with that. So as we saw in this classification from D1, D2, D3, D4, we can also give the bone a kind of density units or a measurement. So this measurement is known as the Hounsfield units. Now you don't have to worry about this. Your CBCT people will give generally a Hounsfield unit. So whenever you are sending a patient for a CBCT prescription to the CBCT center, you always tell the CBCT radiologist to do a analysis and tell you what are the Hounsfield units of the particular bone where you are going to place the implants. Okay, so a D1 kind of bone will have a very high Hounsfield unit because it has high mineral content, and D4 will have a lower. Now, every time we cannot say that D1 is better than D2 or D2 is lesser than D1. We cannot always say that. There are scenarios where we don't want D4, obviously. We want the patients to lie between D2 to D1, which is a really good bone. We cannot always say that because D1 is more mineralized, it will be better. Okay. More mineral content means less blood supply. Less blood supply means less chances of healing because vascularity is not there for healing. Okay, so more resorption can occur in D1 type of bone than in D2 or D3 type of bone. But when there is no mineral content, it means in D4 bone there is going to be less stability of anything we fix into this bone because it doesn't grip that. It's not like a wooden wall or a cement wall. It's very mushy. It's like drilling into like a coconut, which is having almost very pulpy feeling, right? So when you drill into that, you can't expect your screw to hold on very well. So there we need to change our drilling protocols, and there we need to understand that we cannot always say that D1 is better or D2 is better or D3 is better. It is very case dependent, right? Okay, so here we understood the structure of the bone. Again, to revise, the lower part of the bone is the basal bone. The top part of the bone where the tooth is attached is the alveolar process or the alveolar bone. The alveolar bone has these two parts, which is the outer part or outer rim, which is known as the cortical plate or the compact bone, and the inner part, which is the cancellous bone, or which is the bone which is having blood supply. Right. So let's delve deeper into how the bone attaches to the tooth and what are the parts which we need to understand of this periodontal apparatus. So we have this we have this compact bone outside, we have this trabecular bone in between, then again we have a layer of compact bone here, then we have the pedial ligament and the tooth. So this part which attaches the tooth to the fibers and the fibers to the bone, this part of the bone, internal part which is facing towards the tooth, is known as the bundle bone. Okay, so this part, this internal area, okay, this exact area, yeah. So the part of the bone which is attached from the buccal side to the tooth, the pedial fibers will actually go and penetrate inside the bone and fix the tooth inside the bone. Okay, so this part is known as the bundle bone. This bone is very important in implant practice, in implant surgeries, because this bone gathers its blood supply mainly from the periodontal ligament fibers. From this area it gets its nutrition. So let's see deeper. When the thickness of the bone increases in somewhere here, I think everybody can see my cursor, right? Somewhere here, then
Yes.
yeah, so then the blood supply of this particular bone comes from the trabecular spaces which are present inside the bone, and it comes from the gingiva. Okay, from the outer side, it comes from the periosteal layer. But as we move up, this trabecular space becomes very thin, right? You can see these gray areas becoming very thin. So as it progresses up, the blood supply of the bone is becoming less and less. So where does it get its blood supply from? It gets its blood supply mainly from the periosteum of the outer side and the periodontal ligament fibers of the internal side. Okay, so this area, the trabecular spaces are becoming less. So this bone, it's getting its blood supply only from the periosteum of the outer side of the plate and the internal pedial fibers and the vessels which are here. It's not getting its blood supply from within the trabecular spaces of the bone. Okay, so if we cut off this blood supply, and if we cut off this blood supply, what will happen to this bone? Can anybody
Resolve.
answer? Yeah,
Will resolve.
it will resorb. Okay, it will resorb. And that's exactly what happens when you remove the tooth. When you remove a tooth, what happens? This blood supply is severed off, and on top of it, if you have raised a flap, this blood supply is gone. So 100% this buccal bone, this plate, this bundle bone is going to resorb. Okay, till what level will it resorb? It will resorb till the level of wherever the maximum trabeculae are present to support its healing, to support its deposition, right? So that has been uh, the sequence of bone healing after the extraction. So whenever we do any extraction
Sir,
procedure, yes,
uh, do we need to take the screenshots of this, or you will be
no,
sharing
no,
it,
I
the
will
PDF
share.
later?
I will share.
Okay,
Don't
okay,
worry.
okay, sir. Yeah.
Okay. Yeah. Okay. So when we extract the tooth, what happens to the bone? What happens in that area? Now this is important to understand clinically so that we can plan when to do the implant. So imagine a scenario where a patient who is young, about 25 years old, has come to us with a broken tooth, which happened just yesterday consequently in our clinic, and she wanted to replace the missing tooth or a broken tooth. So how do we decide, when do we decide, when do we place that implant? Okay, so what will happen if we remove that tooth on that day? On that day, what will happen? There will be bleeding, then the clot will get stabilized. After about 2 weeks, the clot will start filling with a woven bone, which is a very immature type of bone. After about 4 weeks, what will happen? the socket is completely sealed. From the top area, you will see that complete epithelialization is there. After 2 months, you will see that the upper area, the bridge, the hard tissue bridge is formed and the bone is closed from the top, and internally it is starting to form a little bit of periosteum, which is the blood supply of the bone, the covering of the bone. And then after about 4 or 5 months or maybe 6 months, a good quality of bone will be formed. Woven bone will be formed completely in about 2 months, and then it will start getting replaced with more and more mineral content, more and more lamellar bone, depending on the physiology of the patient, depending on whether they have diabetes or not, depending on whether they have good amount of vitamin C, vitamin D in their body, depending upon the calcium metabolism of that patient. All these, this woven bone will start to mineralize. Okay, so woven bone will form in all the patients except patients who are undergoing bisphosphonate therapy or patients who are undergoing radiation of the jaw or chemotherapy, which reduces the blood supply of the bone. All right. It's not that in diabetes woven bone will not form. It will form. It's not that in nutritional deficiencies woven bone will not form. It will form. But the quality of mineralization will happen, which happens after woven bone is formed, is going to be dependent on the physiology of that particular patient, and that is something which we cannot control. We have to educate the patient about that. Okay, so when we remove the tooth, what happens to this buccal plate or buccal bone or this bundle bone? Now, why I'm saying buccal in place of bundle? Because most of the times our teeth are placed buccally on the jaws. The lingual side or the palatal side is more thicker in most of the cases, and the buccal side is more thinner. That's just the anatomic placement of the tooth. This alveolar process, the buccal side is going to be thinner. When it is thinner, it will resorb over 2 months or 3 months, and it will come to a point where it reaches as much as trabecular space nutrition it can get. So it will stop when the trabecular spaces are wide enough to supply bone, to supply blood to it, right? So I hope everybody understood the importance of these diagrams. Are we clear, or do I need to repeat anything?
Sir, what precautions should we take in the case of bisphosphonates and diabetes we just
Ah,
discussed?
great question. We'll cover that in the next lecture. We are going to cover indications, we are going to cover the medical history and everything. Okay?
Okay.
Okay. So
Sir,
today's
one more question.
huh,
So, sir, while you were speaking about the bone density,
hmm,
so how are we going to evaluate between the bone quality and the quantity during the initial assessment?
huh. Very nice. We cannot assess the quality of the bone without a CT scan, without
Yeah.
a Hounsfield unit, and without actually penetrating the bone. Okay,
Okay, sir.
we can make a guess of how this bone is looking on the X-ray by evaluating the X-ray, by evaluating the CT scan,
Okay.
by looking at this X-ray. See, so on the screen we have this cortical border and we
Yes.
have the cancellous bone. So if this cortical plate is very thin and the cancellous bone is more, okay,
Yes.
we understand that okay, now this plate is going to resorb faster,
Okay.
right? You
Right.
get it. See this, there is
Yes, sir.
hardly any cortical plate over here. It is
Yes.
present, but in the CT scan it about 0.2 mm in the slice will not be seen. Okay,
Okay, sir.
so if we remove this bone, the tooth, uh, can, can you understand that about here this bone will settle, right? If I remove this tooth and I
Yes,
don't
sir.
do anything, I don't do any socket preservation, I don't do any bone grafting, I don't do any implant placement, what
Yes.
will happen to this thin sliver of bone?
So it's going to resorb.
It's going to resorb because the only blood supply it was getting was from the flap, from the gingiva outside the
Yeah.
periosteum, and
Periosteum.
from the PDL fibers, right?
Correct.
So
Correct.
when the tooth is out, the PDL is out.
Yes, sir.
So everything is going to resorb and it is going to come till here. Okay.
Okay.
So exactly like in this situation, it's going to resorb buccally. Palatally, it may still be present till here, somewhere here. Okay, so it's going to go like this. It's going to slope down like this.
Okay, sir.
Okay, so in this scenario, this is what is going to happen. In another scenario, can you see this buccal lingual bone and this buccal bone is very wide here?
Yes, sir.
So this is not going to resolve a lot. This is quite a
Yes,
big bone. Okay.
got it.
So in this manner, by taking a CT scan and a sagittal section in a X-ray in a IOPA, we cannot see the sagittal section of the bone. We actually only see the mesodistal dimension.
Yes, sir.
So there we cannot really identify the cortical plates. In the CT only we can understand the cortical plate. Okay.
Yes, sir. Okay. Thank you, sir.
Thank you. Any other questions at this point?
Sir, as you told, bundle bone is very important,
Hmm.
okay? But in CBCT, how we will evaluate the assessment of the bone, because we only have the density, bone density, which is there.
Hmm. So see this over here. In this CT scan, you can see the plate, the facial plate.
Yes.
Okay. Can you identify in the CT that this bundle bone is very thin?
Okay.
Okay. There are many cases where the bundle bone is very thick. The facial bone is very thick.
Okay.
Okay. So in those cases, the resorption is going to be less.
Okay.
Okay. So this is how we can evaluate. Or did it answer your question? Or can you ask once more?
Mm, yes, kind of, because the diagrams which you showed for
Hmm.
the bundle bone,
Hmm.
this and correlation with the CBCT, I'm not getting that. How
Okay.
we will, yes, this diagram and the CBCT, how we will correlate with this,
Hmm.
both of them.
Okay. So this is a very zoomed in view. Approximate thickness of a buccal plate or the bundle bone is about 1 to 1.5 mm. Okay.
Okay. Yes.
So now how does this if affect us? Okay. That's the second slide. When we see the bone phenotype, then we plan what kind of treatment we want to do. We tell the patient that there may be some bone loss which is inevitable and we have to plan for that gingival recession or that bone loss which is going to occur. Okay, and we will use all these evidence based techniques which I'm going to tell. Okay, so we'll come to that part also where you can actually see in the CT scan. I have more CT scan images to show where this plate is a little thick. Okay, in this example it is very thin, so you cannot appreciate it. But
Okay.
can you appreciate this palatal bone?
Yes.
So this is the buccal, this is the bundle bone of the palatal side. Okay. So do you think that this is going to get resolved as soon as this one?
No, it will not resolve to a greater extent.
Yeah,
Yes.
exactly. So that's all what we want to understand about the bundle bone, which there is a classification of facial bone which tells us if the bone is thin, what do we have to do? If the bone is thick, what do we have to do? Okay. So we'll come to that.
Okay.
Right now we are understanding what is the bundle bone. Okay. So please write down this question. Uh, if it doesn't get answered, please ask me again at the end of this lecture or in between or in the course. Okay, so we can actually show it to you on the patient how it looks. Okay. Sure. So now when we have understanding of the bone type, the alveolar bone, the basal bone, now we can talk about something which is directly related to the implant, which is osseointegration. So what is osseointegration? It is just a structural and a functional link between the bone and the implant. So it is applicable in any kind of implant or any kind of processes which is fitted inside the human body. It is not only about dental implant. Okay, it is about orthopedic implants also. Like we have this implant in the femur, this is also an implant. This also is actually helping in supporting the patient, and this also has to be understood that this is where actually osseointegration developed. So orthopedics used to use this phenomena many years ago, and this actually extrapolated to our dental science. But what osseointegration depends on? It depends on the direct bone to implant contact. Now that is why it is so important to understand the bone type, bone quality before we do the implant, so that we can maximize this bone to implant contact. And there are so many things which we can do to maximize this bone to implant contact. It is known as BIC, bone implant contact. Okay. Now, when we have biological and mechanical integration, where actually the cells of the bone are going to fix onto the surface of the implant. Now, the implant surface also has to be very biocompatible. It has to be made in such a manner that the cells are actually attaching onto it, and uh, they are not repelling to from it. They are going inside, they are attaching to its surface, and it gets fixed. There should be some stability. That successful osseointegration only occurs when there is a stable, it's not moving, it's there, it's stable, and it has a load bearing capacity. And what it depends on is the healing period. So after the surgery, what kind of healing is occurring inside that physiology is going to determine what kind of osseointegration, what is the quality of osseointegration which will happen, right? Then so many factors about implants which are surface of the implants, which we will talk about: the chemistry, the material, the type of implant, the screw, the pitch of the implants, the surgical technique which we are going to teach you in the hands-on of how to actually do the implant surgery, how to drill, which is going to determine what quality of integration is going to happen. The quality of the bone which the patients has. So there are so many systemic conditions or uh, other conditions, nutritional conditions, lifestyle conditions which may be affecting the bone quality, which we need to tell the patients before we actually do the procedure. And there are so many patient factors like smoking, like health condition, which can actually affect the integrity of the implant. So just like we orthopedics give prosthesis, we are no different. We give a dental prosthesis to the patient. And this is exactly how the osseointegration happens in the mouth. Now, I'm not going to go into a lot of detail of the histology or the biochemistry of this because it is not very relevant clinically. I will only talk about points which are relevant clinically. Okay. If we want to discuss about academically, if anybody has interest, we can take it away from the lecture after the lecture is done. So what we need to understand, when we are placing the implant, there will be like how exactly we drill a hole in the cement wall and we screw. Okay. So when we screw, the screw has some structure, the screw has some threads, it has some screws which actually hold on to the cement. Okay. So when it holds on to the cement and it doesn't fall is actually the primary stability, the mechanical stability of that particular screw. Now that primary stability always stays there in the cement wall because the cement wall is not bone, it is not a human, it is not going to change over time, it is a non-living substance. But when it is a living bone, it changes. How it changes? When the primary stability occurs, the primary stability means the first day when you place the implant inside the bone, the kind of screw threads which are there in the implant, they affect the stability of the implant when we put in. The drilling protocol which we have done actually depicts what kind of stability we will have. So imagine if you're drilling inside a cement wall and you made a hole which is bigger than the screw which you have. So what will happen? The screw, when you fit it in, it will be very loose, right? So when it is loose, it will not have any good stability. So that is known as the mechanical stability, the primary stability. It will be very less or almost no. But if you have drilled a hole which is almost matching the size of your screw, then you will have some predictable stability. If you have drilled a hole which is smaller than the size of the screw, then what will happen? You will really have to force and apply a lot of pressure to put that screw into the cement wall, right? So at that time, what can happen? Either the edges of that wall can break a little bit, or your screw can get stuck inside and it will not move inside or may not come also outside, or there can be fracture of the screw. So all these things can happen in the patient also, and they can happen worse because it is a living patient, right? So that's why it is so important to understand what we are actually doing. Did everybody get the point of primary or mechanical stability, or is there still any confusion about it?
No, sir, got it.
Got it? Okay. So that is the primary stability. Primary stability is not a factor of the patient's bone, the patient's response, physiological response, diabetes or anything. It is just the drilling protocol which you do in the mouth. Okay. Now we come to the next stability. Because it's a living bone, the primary stability is not going to be there. So if you have hung a frame on your wall with a screw, that frame is going to be there for many years unless and until you actually remove the screw. Because the cement wall is a non-living substance, it is not going to undergo any resorption or any deposition or any turnover of the bone. It is not going to bleed. But when you're doing it on the patient's bone actually bleeds. It is going to undergo resorption. How it will undergo resorption? When you drill and you fit in the implant, on that particular day when you fit the implant is going to be very stable. If you have followed the correct drilling protocol, if you have identified the correct implant, and you have correctly done it according to the quality of the bone which the patient has, that time you will have good stability. But that stability is going to vanish over a certain period of time, because in about 14 days or 15 days, around the implant, around the bone which is there, we get something known as osteoclasts. Osteoclasts are resorptive cells. They will eat up the bone because of the injury. So when you have placed the implant, around the implant you will have the bone on the first day. But if you actually cut out a section of this and observe it under the microscope on the 20th day or the 25th day, you will see that the bone which was present on day 1 around your implant will actually would have resorbed on the 20th day. This bone would have vanished. Okay. And over the next 20 days, new bone forms. That is known as the biological stability or the secondary stability. So on the first day when you have placed the implant, you have the mechanical stability, which is a factor of the type of implant, which is a factor of your drilling protocol, and which is a factor of your technique of choosing the implant in that particular bone type. But as the time progresses, the blood will come, the angiogenesis will happen at about 7th day, 14th day, 15th day. That same bone where you had placed the implant is going to resorb. The osteoclasts will come, they will resorb one layer of the bone. Then on 21st day, 25th day, the osteoblasts will come and they will start depositing more bone. And about 1.5 to 2 months, more and more bone will start forming. After dissolving the initial layer of bone, more bone will form, and you will get a more biological stability on the 2 month or the 3 month mark. Okay. So what is important here to understand in the implant process is, when the first day primary stability is there, after 15 days it goes down. Okay. And it almost vanishes in about 3 months to 4 months. The primary stability is gone. On the first day, there is no biological stability. Slowly it rises. On the 15th day, it is starting to rise. And on 40th day, 50th day, 60th day, 100th day, it is maximum. Okay. So in the total stability of the implant, there is a dip. A dip is approximately at 15th to 25th day. It obviously varies from to implant and patient to patient, but approximately on the 15th day to the 25th day, this stability is lowest, because on this day the primary stability is going down, but biological stability has not got up to a point where it can actually support the implant. Okay, give me a thumbs up if you got this concept. Got it. Thank you. So what is the clinical implication of? Yes, yes, Dr. Vikas.
Sir, do the types of bone D1, D2, D3, D4 plays a role in the mechanical and biologic stability?
Absolutely, wonderful question. Yes, it does a lot of. Now tell me, D4 bone, which is very mushy, will it have
Yes,
good
sir.
primary stability or bad primary stability?
Obviously bad primary
Very
stability.
nice, very nice. D1, will it have good primary stability, bad primary stability?
Good primary stability.
Very good. So, yes, the bone quality, type of implant, drilling protocol is
Okay,
is that actually ensures primary stability. Okay. What
okay.
ensures biological stability is the physiology of the bone. Okay. Again, the
Yes,
drilling protocol also helps in the biological stability. The bone type also helps in the biological stability. The implant type also helps in the biological stability. But more so, it is the physiology of the bone, the ability of the bone to come, remove the old bone and deposit the new bone. Okay.
okay. Yes. And the resorption that take place from first to 20th day, you said, sir.
Hmm.
So, shall it make implant loose in the socket for the time being?
Absolutely. That's the exact clinical implication which will
Okay.
happen. Okay. So now let me go through uh, a scenario, a case scenario. Imagine
Yes.
a patient comes to you. You have done an implant in the 3-6 region today, 9th of November,
Yes.
and everything is good. You have placed the implant, you have got excellent primary stability. Then
Yes.
you send the patient home. The patient comes back to you after a vacation after 15 days on 26th of November and asks you,
Yes.
Doctor, I ate something and I think I feel my internal feeling is my implant may be loose. Can you just check? Okay.
Okay.
So, yes,
Yes.
as a young implantologist, you want to do something good for the patient. You say, okay, I will go ahead and I will inject you and I will just check how my implant is stable or solid. And you put on your driver and you try to turn the implant. What will happen?
So it might be a little loose at that time.
Yeah. So, do you take out the implant at that time?
We shouldn't
No.
be because it is going to be the new bone is going to be formed there as you explained.
Exactly. Perfect. So the total stability which you achieved on 9th November is going to reduce and it's going to become almost like near to on a scale of 1 to 10 it is going to go to near 3 or 2. If you had it about 10 on 9th November, it's going to go back to 3 on 26th November. So that is not the time when you touch the implant. Okay.
Okay.
On that scenario, you will just say, no, sir, don't worry. Your gums are closed. Your implant is below the level of the bone. Nothing is going to happen. You continue eating,
Hmm.
chewing. I cannot open the flap and check the implant stability now because it is 15 days after the implant. I will check it after one more month. I will check it after 50 days, 60 days. Okay.
Okay.
Got it. That's the clinical scenario. At 60th day, your secondary stability will start coming in all modern dental implants, and you will get the stability back. There is no need to check. Okay. Second
Okay. Got
scenario.
it.
Second scenario. If you have a little bit of understanding of the implant components, you will know that there is something known as a healing abutment or a former.
Yeah,
Okay.
ginger
Is
form.
there anybody who doesn't know about healing abutment or former? Yeah, we know. Okay, so that healing abutment, sometimes we place it on the first day. On 9th November, you did the implant surgery, you place the healing abutment. Okay, it is slightly
Yes.
outside the gingiva. Your patient comes to you on 26th November and says, this healing abutment has come out, can you please fix it back? Okay, what will
Okay.
you do?
We shouldn't touch it.
We shouldn't touch it, so we will not fix it back, we'll leave it.
Yes.
Don't touch that
So we will
implant.
wait for another 20 days around,
Perf
20-25 days.
Absolutely. We can wait for another month to be very sure, and we will then cut open the flap and then we will place it as a second stage surgery procedure, as an implant former surgery procedure, but we will not touch the implant on the 15th day.
Okay.
Okay. Third scenario, the patient requests that I have a meeting on after 15 days and I want the implant prosthesis to be done before that. Can you help me? So we said, yeah, sure. I'm a young implantologist. I will do that. And you go ahead and place an implant on tooth number 11. You place the implant, you get excellent primary stability. You are very happy with your implant. You take the impression on the same day and you send to the lab. After 5 days, you call the lab and the lab says, sir, impression तो मिला ही नहीं. Then you ask your assistant, बोले हमने तो भेज दिया था. So it is lost. Now you have lost the impression. Okay. Now you realize on the 7th day, by the 8th day, you realize you don't have the impression. अब क्या करेंगे? You call the patient again, you take another impression, and by the time you reach to the 26th November, now your crown is ready. Now what will you do? Will you fix the crown on the implant?
No, sir.
No, we will not fix the crown because again at that time we will not touch. So if we are going to load immediately any kind of implant which is primary stable, we have to do it within 7 days. That's the logic behind all immediate loading theories in the world. Okay. If we are going
Okay.
to load any implant, if we are going a full arch case, full mouth case, that's why they say that we have to complete immediate loading within 5 days, 7 days, 3 days. There are so many implantologists which claim that strategic implantology can be done within 3 days. We have to complete that case in 3 days. Okay. That is because if you have promised the patient, you obviously want to deliver it, and also you don't want to delay it more than 10 days. Otherwise, your total stability is very less. Your biological stability has not come. At that time, if you introduce any movements to the implant, it can definitely become looser and the osseointegration will not happen. Got
Okay.
that?
Got
Great. Thank you for asking this question.
it.
Sure. Let's take a break of about 5 minutes, 5 to 10 minutes, a washroom break, water break, and we'll join back. So this way we will also be having